Hey everybody, Karen Anderson here for a special live Q&A. It is Aortic Disease Awareness Month, but Aortic Disease Awareness Week, and specifically we're almost on Aortic Dissection Awareness Day. I know, guys, there's a lot to remember, but we're just so happy that you're with us. And before I get started, I'm gonna ask you to click like, click subscribe, click the little bell so you're notified every time we go live so you don't have to remember like we did just now tonight. So tonight we have Dr. John Martin with us. We're talking everything that's in the abdominal area, but again, free for you to ask any kind of question that you'd like, and hopefully Dr. John Martin will be able to answer for you. Hello, Dr. Martin.
Hello, how are you doing this evening?
I'm doing great. Why don't you tell everybody a little bit about yourself, give them all the spiel of everything you'd like everyone to know, and then we're going to jump right into it.
I can't start with simple country doctor, huh? That's not going to
You
fly
absolutely
here.
can. You can start with song if you'd like.
I'm a vascular surgeon. I practice in Annapolis, Maryland. I'm with the University of Maryland, but I wear a number of different hats. Probably one that's relevant to this topic is I'm the president of the Heart Health Foundation, which is known for the Dare to Care screening program, which has been in existence now for 25 years. We started it here in Annapolis, spread around the country and internationally with the goal of actually detecting, among other things, aortic aneurysms early before they rupture. I've also worn an industry hat. I've been the chief medical officer of a company called Butterfly Network. I'm the chief medical officer of a company called CardioSense, a new startup, and I've had the privilege of working for a number of health systems in executive roles. So I've worn a few hats along the way, but nothing that has anywhere near been as much fun as being here tonight with you, Karen.
Because we just have a good chatty old time.
Yes, we do. Yes, we
I
do.
should have said that in my British accent. Okay. All right, guys.
Jolly good. Jolly good.
Jolly good time, old mate. I don't know what I just did. Okay, that was bad. I mixed a couple countries. All right. So we have been teaching this community a lot about the different zones of our new organ, the aorta, right now that it's been designated that a year or two ago. And so specifically tonight, we're talking everything that's south of your diaphragm, right? So let's talk about what we're going to find in that area coming off the aorta and some of the problematic things that we might experience.
Yeah, and I think the way you can think about the aorta and the abdomen, first of all, it's kind of interesting in the sense that your aorta comes down once it gets through the diaphragm. That first section is pretty high rent real estate where it gives off something called the celiac artery. The superior mesenteric artery is the next one. And then the third one, big major branch, would be the inferior mesenteric. Those are the blood vessels that supply your intestines, your pancreas, your liver, your gallbladder. And then there's two guys that come off to the sides, one to the left and to the right, sometimes multiple, that feed your kidneys, the renal arteries. So the first section is more of the mesenteric, then kind of in the middle is the renal arteries, and then in the bottom, it is the aorta itself, where below the renal arteries. And then your aorta splits to go to your legs, not at your legs level, but about the level of your belly button. So it'll split into that Y, think of it your pair of pants, right at the level of your belly button, where the two arteries then go down to your legs. And those are the kind of areas of the abdomen that we think about with aneurysms. And the different complexities of how we fix them really have to do with which part of that aorta is involved in the dilatation or the dissection.
So first of all, how do we even figure out we have something wrong? What's the typical way? Is it by chance or is it hereditary? What would be the reasons that somebody would encounter there's a problem?
So first of all, and maybe most unfortunate of all, is the vast majority of the time people have no idea they have this problem. It does not cause any symptoms until you get to that big event where it may rupture or a dissection occurs. So for the most part, people that have had aneurysms had them for quite some time without ever knowing it. And either they go to a screening program where it's serendipitously found, they stumble upon it when they go to a hospital for some other reason and an imaging is done, or that acute event occurs that causes sudden pain or rupture or the dissection itself. So the vast majority of aneurysms, far and away, though, are asymptomatic. You have no idea you have them.
Right. Now, I know that in the thoracic area, a lot of that tends to be hereditary or genetic. Is it the same in the lower half?
Yes,
Oh, it
they
does.
do.
Okay, that's
They
good for
tend
people
to.
to know.
Yeah, they tend to run in families. And I always tell people that if there's somebody in your family that has an aneurysm, you're one of those people that has to get screened.
Yeah.
What I do whenever I have a patient that has an aneurysm I'm operating on, the very first question I ask them, after obviously the details about them, is who else in your family is alive? Do you have siblings? Do you have parents? Do you have children? And how old they are, to make sure all of them get screened. Because I can share with you, as many clinicians can, a sad story of someone who I took care of that had an aneurysm and I fixed it and I asked them about family members. told his brother. His brother never did anything about it, and I'll still remember us to this day. Unfortunately, his brother passed away of a ruptured aneurysm that we very easily could have fixed had he taken that step of going to get it tested.
Right. All right. So talk to me about testing. What's involved? Because we know when we're doing thoracic, you hear golden standard is a CT. Next would be an echo. So is it the same when it comes to the lower half?
So the beauty of the abdomen is ultrasound is really a great test. And so you can do a simple ultrasound examination of the aorta, you get a pretty good look of the aorta, particularly if it's dilated. And so you don't have to actually go through all that X-ray imaging. You can use something that doesn't have ionized radiation. Very simple, easy test, right done at the bedside that you can quickly diagnose whether or not somebody has an aneurysm. Very simple and painless.
See, and I think that's what probably scares a lot of people. Either they think they're not at risk because my family member had something in the thoracic aorta and they're like, oh, well, I'm fine. Mine's been checked. That was checked with an echo. It's fine. And so they don't realize, well, no, you really need to have the whole entire aorta. There's no there's no roadblock that says, oh, well, you're from the top. You don't get to come down to the bottom neighborhood, right? So I think that's where there's a lot of a fallacy there. So glad that
Well,
you're
I think
glad that you mentioned that.
I think one of this maybe the saddest part about this is the fact that, we know what an aneurysm looks like when we see it. We know how to actually look for it with an easy test. We
Right.
know how to fix it, and we know what happens to people if we don't fix it. So here you have a painless, simple, easy test and can determine, do I have an aneurysm or not? Because if you
Mm-hmm.
get to be 65 or 70 and you don't have an aneurysm, you're not likely to get one later. So
Mm-hmm.
get the test once. It's a really
Yep.
simple, easy thing to do, and it could save your life.
Now, am I mistaken? I thought that I read that insurance covers men over the age of 65 that might be a smoker. Might be getting this all wrong.
No, you're actually spot on. So
Oh,
men
okay.
65 to 75 who have ever smoked, it's a covered thing. But I'll say this in defense of the finer sex,
Mm-hmm.
you get aneurysms too.
Yeah.
And so what it really boils down to is the statistical analysis of what, cost versus benefit. What I
Mm-hmm.
like to tell people is, yes, you may not qualify and having paid for it. There's a lot of
Right.
screening programs that could be available to you. Um, Plus, there is this kind of gold standard. How about a physical examination?
Sure.
Candidly, if you have a big aneurysm and you're not huge, you can feel these things too. It's
Mm-hmm.
not a reliable way, but it's certainly
Yeah.
any physician that examines you in this grade group should be looking for, can I feel an enlargement of the aorta? Big aneurysms are easy to feel. Little
Right.
ones are tough to feel, but big ones are
Yeah.
easy to feel.
Would you feel, I think that sometimes people, when they're diagnosed with one, all of a sudden start saying, I have stomach aches, I have reflux, and I know that a lot of it plays with your mind. It just does. It has to. It would definitely play with mine. If anybody knows me, I would start feeling all these symptoms that are more than likely not associated with the
Yeah.
aneurysm. I know that. So if people do have one, they normally wouldn't feel something, but then some people do, right? They can feel it pulsating in their belly.
Yeah, what's really interesting for instance, somewhat larger one or really thin people,
Mhm.
you actually put your dog on your abdomen while you're while you're
Yeah.
lying on the couch watching TV, you may see your dog doing this as the
Right.
aorta pulsates. Now you need to be pretty thin for that to be the
Yeah.
case,
Yeah.
but if you put your hand on your belly and you have a reasonable aneurysm, you're gonna see your hands move up and down.
Hey,
It's
fix your
seven.
jump on your camera real quick. But go
Okay.
ahead. Keep talking.
But you have to, if you are not thin, you may not notice that at all.
Right. Okay. Okay. So now we know that it's an easy test. It's non-invasive. It's an ultrasound, for goodness sakes. You don't have to worry about radiation. You don't have to worry about being allergic to dye. You don't have to worry about a 45-minute long MRI if you're not getting this included in your normal scan anyway. If somebody in your family has had an aneurysm at all, you should probably have your abdominal included when you have it checked. So let's talk a little
Absolutely.
bit.
That should not be a
Yeah.
debate at all.
So is medicine like first line? Like with when people who have it in the thoracic, they are on beta blockers, they're on ARBs or ACE inhibitors, different medication. Does that ring true if somebody finds out they only have, and I know I'm not diminishing it, but they have an abdominal aneurysm?
So I think you step one of the things is step back and say, well, who's at greater risk? So it's not
Yeah.
just family members. So people that have smoked, people that have hypertension, those are kind of the groups, and then people that have genetic abnormalities. And there's a
Mm-hmm.
few chromosomal abnormalities that are actually out there that put somebody at a higher risk. So
Okay.
first of all, you want to identify what are the things that make me at elevated risk, and age
Right.
being a big one. They don't
Mm-hmm.
generally happen in 30-year-olds; they happen in 70-year-olds.
Okay.
Once you know that you have one, let's say, and it's not big enough that it needs to be fixed, and we'll get into that. You want to
Mm-hmm.
control your blood pressure. You don't want to smoke. If you have diabetes well controlled, cholesterol should be managed. And so
Mm-hmm.
get those vascular risk factors under control, and that accomplishes a couple things. Certainly, if you stop smoking, control your blood pressure, that helps with stopping the growth of aneurysms.
Right.
Some of it's Mother Nature, but some of it you can control. The flip
Yes.
side of that, overall, you're going to be healthier, that if you ultimately need to have it fixed, you're going to be in
Right.
better shape to get it fixed.
Mm-hmm. Mm-hmm. Exactly. Okay, so we're talking now about lifestyle. We're talking about the genetic possibilities. Um, are people given medication if they have an
Generally
abdominal?
not. Generally
Okay, so
not.
it's not
There was a lot
medically
of talk around a
just
number of things before. They've been tested,
okay,
but at this point, it's not a beta blocker for everybody with an aneurysm. That's not
right.
necessarily been shown. There is one, and that's experimental only. There's a company doing research on kind of a combination procedure and medication where they deliver a medication through a drug-eluting balloon that binds to elastin, one of the substances of the aorta, that has been shown actually to stop the growth of
Do
aneurysms or
your
slow it down.
do your camera.
Um,
Sorry.
Good Lord.
I'm just letting you know. I'm telling you,
Mother
there's
Nature
a
is playing with
storm.
us tonight.
There's a
Yes.
storm where you are, and I know it's jacking up your camera, so that's okay. Keep going.
Yeah.
Yeah, let's go back. Rewind that. Let's talk about this one treatment option that might be
Yeah.
coming out because
Yeah.
it's very
There's a
fascinating.
it's a really interesting company,
Yeah.
Nectaro. They developed a procedure and a drug together where they've discovered that part of the problem with your aorta, you have a substance called elastin that allows
Yep.
your aorta to have elasticity. Well, you're born with a fixed amount of it and it degrades over time, particularly faster in people that have an aneurysm.
Mm-hmm.
Well, what this does is it binds to the elastin and stops
Okay.
the degradation and therefore slows or arrests the decompensation of the wall of the aorta, slows the growth of the aorta, and may ultimately prove, again, experimental, to keep people from having to get it fixed. It just stops it in its
Right.
path.
Right. Which is pretty amazing. I'm just going
It's
to keep
very
saying
cool.
camera. I'm just going to keep saying camera. I'm going to fill it in for you when you do that. So basically what you're saying is there's this potential new treatment that's going to it sounds like from layman's terms going to coat the aorta and in a sense makes it stronger and keeps the aneurysm from growing
That's
because
exactly
your
right.
alternative to fixing it would be what?
Well, the alternative, it ruptures or you fix it with an
Right.
operation. And
And
there are
how are you
two major
fixing it?
ways. Yeah, there's two major ways of fixing it.
Okay.
One is you make a big incision in the abdomen, open it up, and hand
Mm-hmm.
sew a new aorta, if you will, a graft that
Okay.
replaces the aorta. The newer way we fix it, which is quite exciting because it's much less invasive, and
Mm-hmm.
that is we sneak in from below, from through your
Mm-hmm.
groin level, and reline the aorta from the inside. So
Okay.
basically, very similar to the way they fix sewers these days. They used to dig them
Mm-hmm.
up and put new ones down. Now they
Yeah.
slide new pipes inside. Well, that's what we do with endo, and it's a great slick procedure. Now can
Mm-hmm.
be done almost with no incisions. One night in the hospital, and you go home the next day. It's quite
Amazing.
spectacular, the difference.
That is amazing. That's amazing. Your camera doesn't like you, John, but I'm just going to keep saying camera, and you know what I mean.
I'm wondering why the world doesn't like me tonight, other than this
Okay,
storm.
I
This is an
like you. I
unusual
don't
thing.
know. I don't know. It's just bizarre. It's just gremlins. It's solar flares, gremlins, and storms. Okay, so you just said that it might be like one night procedure. How long is recovery if you have to be cut open? It's not as bad
That
as your sternum.
weeks,
What's worse,
weeks. I
actually.
tell
Yeah.
people 4 to 6 weeks before you're really back
Yeah.
on your feet because it's a pretty big incision in your
Yeah.
abdomen. You open the book up completely to get in there and to
Yeah.
fix this. So
I've
a
had
couple
like
days in
4
the
abdomen surgeries, and I would tell you that to me, they are harder than your sternum any day.
It's tough.
I
It's
know.
tough. It's a
Yeah.
tough recovery. And candidly, afterwards, also part of the problem is a lot of people get hernias in that incision because the same weakness that's in the wall of the aorta is in the lining of your
Right.
abdominal wall. So it's very often people can get hernias afterwards.
Yeah, yeah. Do you find that it's more male or female or the
It
same?
is, we get to own the majority of these things, but we're not the
Okay,
only ones that have them.
right.
So it
Which
is
is
more
important.
likely in males than females. Yes.
Do you find that, do you find that there's a certain connective tissue disorder that causes this, or
Yeah.
is it found predominantly more in others?
No, it's that you see it the same thing like you talk about Marfan's and some of the other connective tissue disorders. That's the more rare genetic
Right.
form. I think
Okay.
the more common versions are ones we'd say run-of-the-mill aneurysms that are typically in smokers and males who are over the
Mm-hmm.
age of 65. That's the typical
Mm-hmm.
thing.
Okay. And so, um, and we've already discussed this, but I want to make sure your camera. I want to make sure that this is kind of fun. It's like
I think I'm trying to find out, is there somebody in the neighborhood that around here that's sandbagging me, or is there some little
I
gremlin
like
out
just
there
going.
that's Maybe
I
we could
think
have a
that,
little code, you know, like
yeah, right.
this or
Well,
something. I'm sure the worst part is I'm sure we're torturing our audience, and that maybe I should
they're
just
probably cracking up. They're,
turn the camera off and let's see if it doesn't a problem. And I can just have some face doing this while we're going.
look, between your camera and my grays that are not going to be filled in until another week or two, it's we're a pair. All right, hit your camera unless I lost you completely just now.
I'm
Nope, you're
trying to
good.
find out, is there any code on my screen that can tell me I've disappeared? And I haven't quite figured that out yet.
Well, Josh keeps blinking and I keep gunslinging at you, so that's as good as it's gonna go. All right, so
I think
it's so
he's sandbagging. I think he's doing it actually to make me
he
look
might
bad.
be.
Or maybe it's the competition across town. Maybe that's it.
No. I do think it is very important though that people understand, because this I think there are messaging that is out there that makes it sound as though if you have a thoracic aneurysm, you're not going to get one in your abdominal.
No,
And while thoracic, and this is going to be something I think is interesting, thoracic aortic aneurysms, when they rupture, tend to be fatal because you have such a high volume of blood flow. But let's talk about if an abdominal aneurysm ruptures.
same thing. Same
Exactly.
thing.
Yeah.
Yeah, this, and you know that you have, and the statistics vary, but you
Yeah.
know, generally about a 90% chance if it ruptures while you're at home of passing away if your aneurysm ruptures. If
Mm-hmm.
we fix it, we got a 95+% chance of saving you.
Right.
I don't know. I'm not a Las Vegas odds maker, but it seems to me
Yeah.
like it makes a lot of sense to find it and fix it before it ruptures.
Right.
I like my
So
chances better.
people in this community, they're very big on numbers. Very big on numbers. Why aren't I having my aneurysm fixed if it's 5.2? And I get it, because some people are scheduled for surgery and they don't make it to the operating room because not rupture, they dissect before it gets to that 5.5 or 5, depending on if you have a connective tissue disorder. There's got to be some kind of number parameter. How does that work in the abdominal world?
Yeah, so 5.5 is kind of the magic number, maybe a little bit less for women. We could debate that.
Okay.
And certainly the relative size of the aneurysm to the aorta matters. But
Mm-hmm.
in general, 5.5 is kind of the magic number.
Okay.
And why did we come up with that number? And it's a risk benefit ratio. The
Mm-hmm.
risk of bad things happening to you in surgery and its risk of rupture versus its risk of rupture if you leave it alone. And so
Right.
when you do the statistics with very large studies that have been done, generally that 5.5, you're much better off. If you took 100 people, they're better off that group. If it's 4 centimeters or 4.5, you're better off watching it. That's a
Okay.
nice cue. I like that.
I'm dying. I'm just gonna lose it. I
Wait, I tell
swear.
you one thing, neither one of us are going to forget this one. I will say that. If nothing else, we
This
won't
is
forget this one.
this is definitely going to be a high-rated show. You don't want to miss this live. That's for darn sure. All right, let me do it. Let's do a quick check-in and see who's here with us and say hi and see if we've got any
Oh,
questions so far.
it's so fun. I'm not gonna lie.
Okay.
Hi, Molly. Hi, please and thank
Hey,
you.
Molly.
Hi, Chef. Please and thank you has a question. Wow, not having to get cut open sounds great. Is that an option for emergent surgeries as well?
Absolutely. And actually, that's been one of the really interesting pivots is that if you, and there's some anatomic stuff associated with that, but the short answer to that is it absolutely is. And it's still our first choice to go that direction because recovery is so much faster and it's a lot bigger deal to do emergency surgery open. Please and
Back
thank
to
you. I
you,
like that
Karen.
name. That's a good name. Was
I
that
know,
given
right?
at birth or was that one that was added later in life?
I don't know. All right, Josh, go ahead.
Please and thank you is new to our community. She just started, or he or she just started visiting with us this week at Week in Review.
Very nice.
And back
Okay.
to you, Karen.
I think I saw a question from the audience is how can I trust this guy operating on me if he can't even do a webinar and control his camera? I think that's probably the next logical question.
They'll say you have fantastic bedside manner. Fine. Was there any other questions, Josh?
No, back to you, Karen.
Okay. So complications, potential complications, open versus endovascular.
You mean the complications every other surgeon has, but I never have?
But
Is that
that
the
you've
ones
never had, the ones that
that
you've
I've
heard about
never,
that may or
never
may not exist.
I think, first of all, any major operation, even minor operation, blood loss when you're dealing with blood
Right.
vessels is the first one. So there's
Yep.
always the chance that you could lose a lot, need a transfusion. If your aneurysm ruptures, almost always people need to have transfusion. So blood loss being one of them. Second one, cardiac problems. Typically people that get aneurysms also have cardiac disease. So heart attacks are a very common one, or abnormal heart rhythms afterwards. I think the third one I think about always with any operation is infection. You can get an infection. Those are kind of the big three. But
Okay.
outside of that, there's some technical things. Like, for instance, you could get kidney failure if you were prolonged hypotension and needed a lot of blood. There's a very rare abnormality where actually the inferior mesenteric artery, which often comes off the aneurysm, becomes a critical blood vessel and it gets blocked or sewn off during the repair. You can have ischemia to your intestines, and very rarely, and I'm sure you talked about it with thoracic cases, you can have spinal cord ischemia as well. Exceedingly rare with abdominal cases, but also possible. I think all the complications are much more frequent and more devastating typically when it's done emergently versus done electively, which is why it's so important to screen for these, find them early. We can generally control all of those variables, if you will, in an elective situation where they're kind of thrown at us in an emergency situation.
One of the things that we've only recently started talking about as we've become friendly with Kim McNicholas, who runs Global Peripheral Artery Disease Group, the Global PAD Group. And I think I just really wasn't aware of how often people that have abdominal aneurysms end up having peripheral artery disease. So let's talk about that a little bit.
Yeah, I think it's obviously peripheral arterial disease, for those that aren't familiar, is the buildup of plaque inside arteries, and what it can tend to do is narrow the artery. So now you have a combination where the aorta is too big, the wall is dilated, but the inside, the lumen, if you will, the pipes are full of stuff that blocks the blood flow through there. Now, why is that a problem? Well, if you're going to bring a device up from below, and you can actually see me to do that, you actually have to get through that blockage to be able to deliver the device. So the combination of the two things can certainly complicate the procedures themselves. But it's the aorta. Sometimes when the dog comes in from outside, they got ticks. Sometimes they have fleas when they're scratching. Sometimes they have both. And it's not uncommon that people have aortic aneurysms and peripheral arterial disease at the same time.
Okay. But you could have one and not the other. It can go
That's
either
correct.
way. Okay.
Think about the
Because,
risk factors for PAD are the
right.
same ones: hypertension,
Okay.
smoking, diabetes,
Right.
age,
Sure.
males. They're all very
Yeah.
similar.
Didn't even think about that. Now, what happens when you have a female who's pregnant and you find out she has an abdominal aneurysm? I don't know why I thought of that. Like, it's such a hellacious thing I just came up with in my mind. But you probably wouldn't, because you're saying it happens older. It wouldn't be somebody younger.
I think
But
probably first of all, I call National Enquirer because it's probably an unusual story. No,
I
just
mean, it
kidding.
happens. People
It
who are
does.
pregnant have issues with aneurysms they didn't know. I never understood why, when a woman has um, preeclampsia, why nobody ever thinks to do an echo before she begins pushing. Like, why wouldn't we look and see
Well,
what's
because
happened over 9 months?
first of all, they're exceedingly rare, but can happen. The
Hmm.
etiology of the aneurysm is probably a little bit different,
Okay.
more commonly maybe associated with infection that weakens the wall of the aorta. But when we're younger, fortunately, our aortic wall is stronger. That
Okay.
elastin and fibrin it's pretty well. It degrades over time. The years on this
Hmm.
planet tend to weaken it. So the aorta itself, and typically of women of childbearing age, is pretty strong and can stand up to, not impossible, but it would
Hmm.
be a very unusual circumstance, and certainly very complicated, because typically x-rays and those kind of radiation
Right.
images are used to do minimally invasive things, which obviously is a challenge for the fetus.
Okay. All right, so I'm going to go back to this again because I think it's important. If a lot of people know that their dads might have an abdominal aneurysm, I don't see why anybody should ever brush that off and not think, let me just go get a big scan, which my father had an abdominal aneurysm and I never thought to go have my aorta scanned until things were too late and I discovered I had an issue. So again, you would say that it doesn't matter if they're 68 and they find this out. This is not just something that's a man's disease. And just don't worry about it. That's theirs. You should talk to a cardiologist and say, you know what? My dad had this. I'm wondering if I should just get a baseline.
Yeah,
Do you
and
feel that way?
I think it's important that people get
Yeah.
screened. And candidly, if you find some level of structure, there are other organizations out there that do screening. Our
Mm-hmm.
program, Dare to Care, we screen anybody over the age of 65, anybody over
Mm-hmm.
the age over 60, anybody over the age of 50 with risk factors, will do it
Okay.
for free. But there are
Okay.
organizations, Lifeline Screening, for instance, does
Mm-hmm.
hundreds of thousands of screenings across the country. You have to pay a little bit of money for it, but a little bit of money for a lot of life is certainly
Yeah.
worth it. And so
Yeah.
I think if you're worried about it, if you're in the right risk group that we talked about today, certainly if you have a family history,
Mhm.
don't pause. Don't hit the pause
Right.
button, hit the go
Right.
button and get it done.
Right. Absolutely. All right, Josh, I'm checking in with you again because we're zipping through things because I don't want this storm to keep causing the camera to go out. Anybody else have comments other than hopefully chuckling?
Let's catch up here. I'm looking at thank you for your answer. Pleased and thank you refers to my preference for manners. Wonderful to hear.
Oh,
I like that.
Uh,
That's
you
really
are
good. In
very
this day and
welcome.
age, that is really nice to hear.
I like
Thank you
that.
for that.
Mm-hmm.
right on. And Molly asks, Dr. Martin, do you just discharge and or follow up with your open heart surgery patients regarding their emotional and mental status?
Oh, good question.
I really like that. And so my family is big into mental health. My brother is a psychologist and does a whole host of stuff. I grew up actually volunteering at back in the old days where there were mental institutions. I volunteered at one. My mother was the coordinator there. So mental health is a big part of the way I practice medicine, and I think it is a key part of recovery. So yes, I think a big part of getting ready for surgery is the right kind of emotional support that you can give somebody to put them in the right frame of reference. After surgery, it's providing the right kind of support, understanding that there is post-op depression. There are a lot of things that people have to deal with in their lives that make a difference. So the long and short of it is absolutely. I think what's really helpful is to have, excuse me, a surgeon that understands that and can be sympathetic to that, and also treat every patient like that's the first and only and most important operation they're ever going to do in their life, not the 1000th one they've ever done, because it's likely the only time you're ever going to have this one. And I think that's something I try to bring to the bedside every time. The right kind of confidence that I can take good care of you and solve your problems, but the right kind of personal approach to know that how special this is for you and how special a time this is in your family and surrounding circle's life, to make sure that you deliver on both the technical aspects of this, the medical management of the disease, and the emotional support to get through a big operation.
Mm-hmm. Because it is hard. It's hard if somebody finds out they're sitting with 4.7 and then they just got to sit for a while, or the next year it grows 4 point, I don't know if you consider 4.7 to 4.9 actual growth, right? I always thought it was 3 millimeters or more in a year. I don't know if it runs true in the lower half. I'm not too familiar, but let's say it goes up to 5. And now they're still sitting, and then there's nothing worse than being in a watch and wait time period, and you're just waiting for it to grow in its time, or you're waiting for it to rupture and you're hoping you make it to a hospital. So I mean, do people have just can they also just have a dissection from that aneurysm, or is it just aneurysm or rupture?
It's typically rupture. The dissections typically we talk about start up in the thoracic aorta are most of the
Okay.
ones there's certainly dissections that are just in the abdomen. It's a
Yeah.
little bit less frequent than the typical dissections up in the aorta.
Okay.
I think the other thing is maybe that's worth mentioning too. Now, one of the roles I had in my life was, and still have in a part-time role, is being the chief medical officer of a company called Butterfly that built the world's first handheld ultrasound device. And why is that important? Because in medical schools all across the country and now residency programs, they're teaching doctors to be able to do their own ultrasounds at the bedside. So instead of being sent off to a radiology department to get an image, which is typically done, doctors are learning how to do the scans themselves in a family medicine office or in an emergency room and stuff. And so I actually have a Butterfly, and when I practice, even if you didn't come to see me for an aneurysm, I look because I can take a quick look. And so that's a very useful tool. For instance, if you don't meet the guideline criteria, you should have another one in 6 months or 1 year based on guidelines. The guidelines don't necessarily treat this. They treat this. And I think it's important sometimes to have both options available for patients.
I could see where if you're in watch and wait, if your doctor's like, let's just take a quick peek, it would put your mind at ease. It really
It
would,
does.
or it would be a big surprise to you. So one way or another, somebody's going to come out of there and know some more information, which is great. In addition to, okay, let me ask you this. Let's just go off track here. What was the largest size aneurysm you've come across that just stunned you, that you were not anticipating seeing?
13 centimeters.
What? No, that's insane. Oh my God. And you didn't see that coming at all? Person didn't feel it? They're just
Oh,
like, oh,
but
I feel a little bubble in my belly.
you could see this at some.
Oh, it was like bulging kind of out their
Oh my
tummy.
goodness.
So like Fido was really moving on their stomach.
Yeah, this was one. Sir,
Wow.
when do you plan on delivering that?
Wow.
Yeah,
Okay.
Yeah, that
And
was
so
a big
you look.
surprise. And candidly, if you look at the statistical odds of that thing getting to that size without rupturing, it's that guy should have bought a lottery ticket. But the good
Wow.
news is, I mean, that there are always interesting stories. I've had
Yeah.
one of maybe the one that's will look at, and people may look at my sick humor, I don't know, but I had a guy come in once with a ruptured aneurysm, and
Mm-hmm.
it ruptured in the retroperitoneum, so not free rupture into the belly. So he had
Yep.
severe back pain, wasn't hypotensive yet, and he decided he didn't want anything done. Now, he was too young really to quit, but that was his decision. You can't force
Mm-hmm.
him. And he said, I just give me some pain medicine and go home. I said, but we can help you. He said,
Mm-hmm.
nope. So he took his pain medicine and went home. A few hours later, I get called by the emergency room. They said, he's back. Okay. I came back in. I said, well, let's go upstairs and fix this. No, he said, you told me that if I didn't get this fixed, I would die. And he
Mm-hmm.
looked at me and he said, I'm not dead yet. And I said, I can see that.
Mm-hmm.
He said, when's it going to happen? I said, I don't know. And I said, let's
Yeah.
go fix it and we won't have it. I know, long story. He basically came back 3 times. The third time he came back, he said, what were my odds of surviving the operation? And I said, it's about 50-50. And he goes,
Mm-hmm.
well, let's go upstairs and see if you can save me because maybe you'll kill me because this is not killing me itself and I'm in pain. So, so we
Maybe
took him
you'll kill
upstairs.
me.
We
That's horrible.
saved his life, and afterwards he was very grateful, which is why I share
Right.
the story. But that you will have some interesting stories like this.
Yeah.
Unfortunately, Dare to Care was born out of a night where somebody showed up with a ruptured aneurysm that we never got to the operating room, and I went home very sad
Yeah.
that that shouldn't happen, and that's when I
Right.
started doing the really aggressive screening in the community.
So talk about Dare to Care. Tell everybody all about what it is and what it involves.
So Dare to Care started. There was a night I was called in for the ruptured aneurysm. Before I left, I saw somebody somebody who was back on camera. They had a severe stroke that came from carotid
Right.
disease. And then
Okay.
before I got out of the emergency room from that one, somebody came in cardiac arrest that I had to do CPR on.
Mm.
Driving home, I said, this is ridiculous. I'm on the back end of disease. I was familiar with other screening programs, but thought about things that were wrong with it. They cost
Yep.
money, weren't available to everybody. And so what I decided to do the next day was start a screening program. It was associated with education. It was going to be free to everybody. All
Mm-hmm.
the information from screening would go back to their primary care doctor. And we started small, but oh my goodness, wow. We
It's
started
okay.
small and then expanded. And so in Anne Arundel County, where I live, we've screened 70,000 people in the screening program for free, spread
Mm-hmm.
around the country and around the globe. And we still are going 25 years later.
It's amazing. It is amazing. I'm telling you, one of these days we're going with you. We're partnering with you. We're screening Maryland. It's going to happen.
We did. We had a fun time a couple years ago. I decided coming out of COVID that we needed to shock people back in. And so we screened in every single county in the state of Maryland at the same day, at the same time. We did 1,000 people in one day.
So great.
Coordinating that throughout the whole state was quite an adventure, but we pulled it off and we
Right.
drove awareness, which is what your mission is and what's so important.
That's amazing. That is. Our mission would be those people that were identified at risk. Let's get that resources to them. Let's get the family and let's get some additional screening and then be there to support them on the back end. So that is wonderful. All right, we're going to check back in with Josh and see if there's any other thoughts or questions. And then you know what, John, I can't believe it, but I think we hit all topics. I think I hit
That's
all the
amazing.
topics.
I think
Right?
the only thing we missed is whatever engineer or video expert that could have clicked us a message and say, do this, and it'll stop.
I don't think that exists
Oh, not
tonight.
with storms. Not with
Nah,
storms.
storms are a challenge. All right, anything else going out there?
All right, so
Going on?
Molly says, great answer, a thank you. Please and thank you says, have you done any aortic repairs that did not require blood products?
Yes. Yes. In an elective situation, very often we don't have to give any blood products.
Very
On
good.
an elective
I know there's
surgery,
been
we don't have to do any blood products.
Often,
plenty of
not
time,
always.
right?
Often.
Yeah.
Okay.
I would
Yeah.
think that's because there's a lot of time to prepare and have
Well,
everything ready. Whereas
you're very controlled in that situation, and therefore, that hasn't already started leaking and blood is out. We've got everything controlled in that environment.
Okay. Okay. All right. Anything else?
That was
Well-
impressive, Josh. Thank you.
We're caught up. I guess we're caught up.
Yes, I'm doing a lot of clicking. I have to be honest. This is.
I
So
know.
also,
I don't know.
Also, please weigh in on the debate for non-abdominal aortic repair, thoracic surgeon, or vascular surgeon.
I'll answer that with good surgeon. because the good surgeons come in both flavors. And I think what you want to find is someone that you personally match with, who has the skill set and experience that will fix it. And I don't think either or other really matters, to be honest with you. My vascular surgeon partners would probably shoot me for saying that, but or be upset with me. And let me be more respectful of things that have happened recently. So I apologize for anyone. But I think it doesn't matter. It doesn't
I mean,
matter. I
because
think
rule of thumb typically would be that we've heard thoracic does chest, vascular can do anywhere.
yeah, and that's typical. But physicians are trained to do what they're trained to do. You
Anything.
want somebody
Yeah,
who's got expertise and knows how to do it
absolutely.
and has experience. And
Right.
I think the label attached to them is less important than the skill set that's in the individual.
100%.
I
Because
like
it's not,
that. Oh,
yeah, and it's not so much, I mean, yes, you're going, we hear a lot of people that want to travel to other states because they hear doctors' names and they just fail to recognize that you've got great doctors at the hospital systems by you. If that hospital has the equipment to be able to handle taking care of your situation, then there's going to be a great surgeon that is there. I mean, you're not going to go to a regional medical center and expect that you're going to have open heart surgery like up here. You're not going to go to a medical center. They're going to fly you out someplace else, but you're not going to have to be flown to Cleveland when you can go and be flown to any place in Maryland. We have so many wonderful hospital systems to take care of you. So
I think,
you're right.
do your homework. I mean,
Yes.
listen, I was a patient, I had cancer. I actually went to all the major cancer centers in the country and I
Mhm.
stayed home. And
Yeah.
I can't begin to tell you how happy it was that I did. There's so much to be said for that. But you just do your homework. There are
Right.
a lot of good doctors in this country in a lot of places, and they're not
Mhm.
all only at the Mayo Clinic or the Cleveland Clinic. They got great people,
Exactly. They do.
but they've trained great people. And those people
Right.
have gone out all around the country.
That's true. That is true.
oh, that's a very important thing to hear. Thank you for that. Um, Molly asks, can you explain the various shapes of aortic aneurysms?
So that question refers to kind of two major types. There's something called a fusiform, which is basically the walls of the aorta kind of expand uniformly, the bulges on both sides, to something called a saccular aneurysm, which is more like you can picture the tire that you have and you see a bulge coming out the side. The reason that distinction is important is saccular aneurysms tend to rupture more frequently and at smaller sizes than fusiform aneurysms. So we do make a distinction between those two. It's a very informed question. So somebody's done their homework.
We do our homework here. Molly's part of the organization, although that's a great question.
Yeah.
So then do you ever find pseudoaneurysms in this second lower half too?
That's unusual because typically pseudoaneurysms, and the difference between a real true aneurysm and a pseudoaneurysm, true aneurysms involve all layers of the wall of the aorta.
Okay.
Pseudoaneurysms is kind of like a false hole. Where we
Okay.
typically see a pseudoaneurysm is if you've had a procedure in your groin, they put a catheter in and then they took it out. What happens is the hole doesn't completely seal, but the tissue around it keeps it closed, and it forms an aneurysm off the side, like a saccular aneurysm, but it doesn't really involve the wall of the aorta. It's the tissue around it that's holding it attached to the blood vessel.
Oh, okay. All right. I didn't picture that visual, but now I have it. Okay.
Yeah.
Makes sense.
Right on. And please and thank you says, thanks for your honesty.
You're welcome.
They asked
Absolutely.
about the weigh in on the surgeon question.
Yeah. Yeah.
Well, I
Well-
think part of being a good doctor is having integrity. I think that
Yeah.
matters. I think that matters in a great way. And being, open and honest and transparent with your patients. Why I also never hesitate for a second when someone wants a second opinion. I always encourage that.
Right.
Um,
And we talk about that too. We created how to ace your healthcare journey through advocating, communicating, and educating. And we try to explain to patients that your journey is not supposed to be a power struggle. This is supposed to be about power balance. And if that includes a second or a third opinion, then that's what it includes. And it's just a two-way street of communicating would lead to success. So we kind of believe that we bring our experience and what we're going through, and the physicians are bringing their expertise. So there's none of this, it's more of this to make it successful and to make everybody as compliant as possible. So
yeah, I always say that the one thing that's not welcome in the exam room or when I'm talking to a family is ego. That they're not welcome in the room. I think it's really all about how do you communicate. And I encourage all my patients, take notes, ask questions, write them down, bring somebody with you, because you're always in the middle of shock with this, and it's helpful to have another voice with you. So if you have the ability to do that, all of those things become really important.
Absolutely. All right, turn your camera on for one last goodbye.
Did I make it back?
Now you're back. All
Now
right,
everybody's saying
listen.
good riddance is what they're really saying.
No, you're doing a great job. And one last check-in before we go, because this is just way too much fun. I hate to see you go. What's going on, Josh?
Yeah,
Anything?
so Molly says, I had saccular.
Mm-hmm.
Okay, and the surgeon was a bit worried about it. I dissected 1 month before a planned surgery.
Wow. But you're doing fine now, I hope. It sounds like. So
Oh,
that's
Molly's a
great.
rock star.
Yeah. Sounds like it.
Yeah.
Yeah.
There's an advocate for all of us. And then, sometimes there's just bad luck. There just is. We tend to practice medicine based on statistics and stuff, but every once in a while, the statistics are not in our favor. But they serve as a guideline for us to follow.
At the end of the day, it's still a human body, and it's still going to do what it wants to do, right?
Yep.
And it is
Like,
what it is. All right, John, you're like awesome. Dr. Martin,
Well,
you're great.
hold on. We
What?
have a little bit of
Yes,
chat
more?
left.
We got a little bit more.
Yeah,
Sorry.
yeah, yeah. Please and thank you says, I see you did a talk on the butterfly story, in quotes. I'll have to watch that.
yeah, there is a TED Talk I have out there. If people are so inclined to be really bored or want something to put themselves to sleep on a night you can't sleep, you can certainly find that out there on the web.
Tell me, what is that called? The butterfly what?
The company is Butterfly Network, and
Mm-hmm.
I did a TED Med talk on that, and it was a little bit about being on both sides of the knife. What's it like to actually be a patient and doctor, and the importance of time? I think a lot of our discussion was the anxiousness. I think if you look at healthcare, I think what was really apparent to me as I started to think about all of this was the role of time. I mean, we're called patients, we're in a waiting room, but you end up waiting to see your doctor and get an appointment, waiting to get a test, waiting to get the answer, waiting to get surgery, and waiting to get better. And I think anything that we can do in the healthcare delivery system to recognize how difficult that time is. That time costs anxiousness, expense, worry, doesn't work for anybody.
Right.
I don't like waiting to do your operation anymore. You like
Yeah.
waiting to get it done, because I'm laying awake at night going, God, I hope she doesn't rupture before that we get to do that
Right.
case.
And I
I'm
don't think
thinking the same
patients
thing.
realize that. Yeah,
Yeah.
absolutely. I mean, and that is so interesting. As a patient, we are forced to have patience, and it is extremely hard. And I also think that probably a lot of the trauma that we end up experiencing when we have a dissection or a rupture, anything that's life-threatening, is that in the ER, we're told, this is life-threatening. We need to move now. Where are we moving you? And I think it all starts there in the delivery, because they're scared, they're freaking out. There's a lot now moving parts and transfer, and it's just told to us so blatantly sometimes that it just shuts us down immediately, and that then stays with us for a long period of time. So I think that too could probably be improved upon. There's probably a better way of delivering the fact that you're probably going to die, so let's decide where you're going. It's a little harsh, but interesting that you talk about the patients as patients. Right. I was just waiting to meet with my surgeon the other day, and it was a half hour in, and I'm video recording all this stuff to make like a little handheld documentary thing, make it as rare as possible. So, true me fashion, I'm grabbing gloves, I'm blowing them up, I'm jazz hands, I'm making them look like chicken finger walking the walls, and he comes right in, and I quickly threw the gloves away. I was so embarrassed. I didn't think I'd get caught, but the one moment I go goofy, he walks right in and interrupted my show. Fine.
Well, the sad part about healthcare is we always say it's about the patients, and certainly
Yeah.
you would like to think it is, but it's not really designed about the patients.
Right.
It's actually designed to
Right.
how can you efficiently deliver care to a lot of people.
Yeah.
And unfortunately, time is the ubiquitous friend and foe that it's always a passenger in our journey through healthcare.
Right.
And my goal is to find ways to try to take it from being an adversary to somebody who can help. And so the faster I can move, the more I can appreciate how waiting creates such anxiety in people, and I can eliminate that, or at least provide comfort that reduces the anxiousness of waiting. I try to do that.
Absolutely. And we as patients appreciate that. Josh?
All right, let's wrap up a little bit of chat here.
Okay.
Molly says, thank you for being here. You two were fun tonight. Come back soon.
With a camera that works.
Well, perhaps there won't be a storm next time.
That would be hopeful.
because I was in the pre-show, I know that you have some lovely
No,
vocal
I'm not going
cords.
to. Don't you
No,
dare.
but I don't. I can put. You can sing us out. I can put up our closing screen.
No, that's okay. I think I'll pass
Look,
on that
I'm
one.
just going to
Boo.
tell the secret. I'm not going to hold you to it, but I'm just going to tell you, I had such wonderful entertainment in pre-show. I did not know that Dr. Martin could sing and was singing me some Phantom of the Opera, and I was I mean, come on, you guys know me. I just
I
sat
was
here like
there. It was
starry-eyed,
amazing.
Let them
starry-eyed.
use their imagination. It's much safer.
So good. I wish we had it on. I wouldn't have played it. I wouldn't do that to you without permission. I promise. All right. I'm going to wrap this up and just say this was probably one of my most fun live events. A technical difficulty that made it very enjoyable, and you make it very enjoyable and easy to understand, which we all very much appreciate. So thank you so much for joining us during
No.
Aortic Disease Awareness Month.
And thank you for everything you're doing. It makes an amazing difference out there, and you are certainly an advocate that everyone should be very proud of having and being associated with.
You are very welcome, but it is truly a group effort. I would not be doing what I'm doing if it weren't for everybody that that helps the organization and is right there alongside of me. So it's an everyday thing, and we're all do it together, which is wonderful. All right, to all of you, do me a favor, click like, click subscribe, click the bell so that you're notified when we go live, because I think we have another live event coming up tomorrow at 3:00 with Robin Peacock from Heart Valve Voice USA. You know Robin, John. She says hi.
All right, give it my best.
I will. All right, everybody. Thank you
All right.
again so much, and we'll see you soon. Thanks,
And good
John.
luck to you, Karen.
Thank you so much. Take
All right,
care.
bye.